I think that there's just going to be a greater understanding that they need to be better educated. Like I said, people are so busy, physicians are so busy, the way that medicine is in this country now, you have to see 40, 50 patients a day to make a living. I don't think physicians are going to want to take the time to become more expert in using these medications. So I think that that's potentially one downside. To some extent it is, and I think truly we're just seeing the tip of the iceberg. I think we're going to hear a lot more about this in the next several months, possibly 2 years. But yes, to some extent, I think it is overshadowing. Of course, because of the issue, because of the concern, because of really the lack of evidence whether to use these medications or not to use them, we need to look for other ways to treat chronic pain syndromes. So I think there will be a lot of entrepreneurs who are out there and scientists who are going to, continue to research and continue to look for alternatives. That is also a very big problem. Emergency physicians are also being educated about this epidemic as well, and they are also changing the way that they do things as a result. And so I see that being less and less a problem. I see them being a little bit more stingy, if you will, about giving IV drugs versus by mouth. And I think by imposing a certain structure and a certain treatment plan, that will discourage the patient who has a tendency to go to the emergency room. I would love to see the growth of multidisciplinary pain centers being built, not only here locally in the tri-state area, but around the country. There are too few. And I think that that's important specifically because there are many components to the treatment of chronic pain besides just medications. I don't think that that's emphasized enough. I think that there's potentially some great benefit there because medications alone do not manage pain. There's no magic bullet. I tell that to my patients every day. There are behavioral modifications. The experts in behavioral medicine are a huge component. And then there is all of the non-pharmacological options that patients either choose not to participate in and/or insurance companies do not appreciate and do not pay for. And the kinds of things I'm referring to are things like acupuncture, manipulative therapies, things even a little bit more esoteric like yoga and meditation, distraction therapies, that all can help a patient at the end of the day better cope with their condition. We've always known that this is the way to treat pain. I mean, pain, has never really been limited from the standpoint of receiving formal education to just pain medications. We've always known that the use of behavioral modification and non-pharmacological measures, exercise, basic things play a huge part. So the fact that they haven't developed is just because the incentive system is not there yet. The insurance companies are not paying for certain important services. And if you're able to develop a service where you can control all of those components, you're much more able to be successful to get the patient to agree and to become a part of doing that. Sometimes financial and economic concerns limit them, and I understand that. We are working on it. We are working on it. I don't know the details exactly, but it's something that definitely we are in the process of developing. We do have our wellness center, which does have a integrative medicine department, which is just being developed, that includes manipulative therapies, includes acupuncture, includes Reiki, it includes yoga as all potential therapies. Certainly, at some point, once we get our resources put together, that department will play a huge part in the care of patients with chronic pain. Well, I think having this position to me has been a tremendous opportunity and blessing to do something that I'm really passionate about, which is palliative care, which is having sort of more of a holistic approach to the care of patients, and to have the opportunity to develop that program in this hospital to me is just something that I can't overestimate how much it means to me. The support that I've gotten, the champions that are in this institution that have helped me put this together, because no man can do it alone, and or woman that is, and so it's a privilege to be able to be in that position, to be able to develop a program like our palliative care program here. Philosophically, no. And as I mentioned, not only on a nursing level, but obviously on a physician level, it's still relatively a small field. When I go to the academy meetings, I'm still running into the same people. We've all sort of grown up together with the same philosophy, with the same goals. Yes, there are going to be little nuances. Yes, the politics is different from one institution to the next. But I think the overwhelming philosophy of what it is that we do, being precise about the language, making sure that we're marketing ourselves in a very consistent way across the country, I think that that's very tightly controlled in a good way. I think most people know where to go, know where the think tanks are, know where the resources are, and we utilize those services in a way that I think is pretty consistent.